Good morning to everyone. I'm happy to talk with you in the next 15 minutes to talk about clinical validation and implementation of artificial intelligence-based solution for acute kidney injury, as you can read there. Just few words to recall you the amount of the problem, because it is important to remind that acute kidney injury is a worldwide, widespread healthcare problem issue. It is near homogeneously distributed all over the world without any particular changes between countries, despite of comorbidity distributions, races, country income, and the incidence in the overall population is about 15 to 20% until near 30%. And this is when we talk about the overall population. But if we can see in the population that we are dealing with, it has the critically ill patients, the incidence of AKI may reach 66%. And the need for renal replacement therapy is about 10% of this patient. This is due because more people are older, there are more comorbidities, and the incidence of AKIs is increasing year by year all over the time. Another important thing to remember is that moderate and severe AKI is associated with a significant increase in mortality patients, with a threefold to near sevenfold higher mortality for patients with AKI stage 2 or stage 3 respect to the people without this kind of AKI. Last thing to remember is that mortality of patients with AKI who needs renal replacement therapy is quite 50%. And this is why nowadays, numerous efforts are made to try to find and to anticipate the diagnosis, as Professor Villa told us just before, the diagnosis of the development of acute kidney injury. This is the actually accepted definition of artificial intelligence from John McCarthy. And in particular in clinical medicine, the most used subtype of artificial intelligence is the well-known machine learning method, in particular the supervised learning method, in which a software, after it is created, it is trained with a huge number of data using numerous data sets, and the software is able to process this data, to learn from them, giving the clinician an output that the clinician must interpret, and on the basis of this output, the clinician have to give decision on how to treat this patient or the pathology is dealing with. This is a recent editorial of the Wiegler and Professor Osterman. Is about a few months ago. They published this article in which they used the KDIGO bundle and the possible application of artificial intelligence in different stages of AKI or in high-risk patients to develop AKI. I want to put attention on the first one because this is the one we need to focus. It is the prediction of AKI or severe AKI in patients at high risk or with AKI stage 1. In the same editorial, there is this table. I know probably it is not readable or fully readable. Anyway, you can find it in the article I'm talking about. And the most important thing of this is that of 42 studies performed in the last 10 years, from 2015 till 2025, 41 of them had a retrospective design and only one had a prospective design. So all of the study evaluated a software to predict the development of AKI just using retrospective data. This is the study with a prospective design that I just mentioned, and this is published in 2019 by Fletcher and collaborators, and they studied 252 patients. They trained their software and validated it in the prediction of AKI stage 2 and 3 development within the first 7 days from ICU admission. But I want to underline that the prediction of AKI development was made only once, at one single point, or better, in 3 single points, but not during all the patient hospitalization. In particular, the prediction was performed at ICU admission, on the first morning after ICU admission, and 24 hours after the ICU admission. So the software, after the clinician had put into the medical record all the variables that the software needed to perform its prediction, the software made prediction at that time points, returning to the clinician the probability to develop AKI stage 2 or 3 in the next 7 days. But we don't know anything about the patient, if a patient stayed in the ICU for more time, or if the risk for developing it changed after this prediction. This is why the U-Care Medical startup, the guys of the U-Care Medical decided to create a new software trying to predict the risk of develop AKI stage 2 and stage 3. The first step was obviously the one to train the software and to validate it retrospectively. It was made with an internal validation using the most common MIMIC3 and Amsterdam UMC database. And using this database, the software was validated retrospectively. There was an internal validation was made. After that, an external validation using a bigger data set, the EICU, that contains more than 200,000 people, and Margherita 3, an Italian one database, the software was validated externally. And in all of this validation, they showed an area under the raw curve of about 0.88 to 0.9, with the sensitivity and the specificity of about 80%. After that, we decided to collaborate with the U-Care Medical, trying to validate prospectively this software for the prediction of AKI stage 2 and 3. And we made it during 3 months. In these 3 months, we enrolled 110 patients, and 110 patients. The software was installed, integrated into the electronic medical records of our hospital, and but the clinician didn't have the possibility to know what the software was doing, how the software was performing. This not to influence the decision of the clinician about this output. After the 3 months, we matched the AKI development with the prediction made from the software. Of all the population, 14 patients, about 15% of them developed AKI stage 2 or stage 3, and there were not any differences in the population studies. The only difference, obviously, I think it was easy to predict, was that patients with a more severe grade of acute kidney injury had a higher mortality than the one without. The same study was conducted in parallel with other ICUs in Italy and out of Italy. This because it is important to study, to validate the prediction rule, the prediction strength of this software with different methods of works, with different electronic medical records, with different medical approach that may change not only in Italian from city to city, from region to region, but also from country to country. This is the result we gave. We confirmed the area under the curve of 0.87 with an average lead time from the prediction of the patient, from the prediction of development AKI stage 2 and 3 to the real development of AKI. Another important thing that I want to underline is that this prediction was made hour by hour during all the patient hospitalization, all the patient stay in the ICU. So not only at one time point, one for all, but hour by hour during all the days they were into the ward. And this is just a screen to show you how this software was then, after having validated with a study the software, we decided to try to use it, because in the validation, as I told you, we did not have the possibility to know how the software were working. In this, after that, we decided to implement the use of our clinical practice with using this software. In the next presentation, you will see better. I just want to give some basic information. This is the main screen of our ward. The red dot here under the voice Akira index means that that patient at a high risk of developing AKI stage 2 or stage 3 in the next 24 hours. So the software gives us an alert telling us pay attention to this patient, because probably in the next hours if you won't do anything, or you will not change your management of the patient, it could be possible that the patient will have stage 2 or 3 AKI. And this is, for example, one patient in which the patient that you saw before, this one, patient at bed number 3. This is when the software gave us the first alert. Then, about 12 hours later, the software, during all the hours, the software continued to monitor all parameters that it needs to make this prediction. And after 12 hours, the software told us that the patient had a new risk of developing a new event of AKI. In conclusion, I want to pass these few messages to you. The first is that identifying patients at risk of developing stage 2 or 3, now it could be possible, it's possible, and thanks to the U-Care Renal Platform, which uses the artificial intelligence-based model that I told you, is specifically trained for this scope. And the risk of AKI, of develop AKI stage 2 or 3 in the next 24 hours are dynamically monitored hour by hour during all the time in which the patient is stay in the ICU. Obviously, an early prediction of developing AKI stage 1 or stage 2 or 3 can make the clinician in the condition to make decision that can that can impact in a positive way on the patient's outcome. In particular, I want to underline that during the more difficult hours of the management, for example, during the weekend, during the night hours in which we can lower our attention to the patient, the software continue to work and give us alert to recall us attention to make sometimes even just little changes. For example, optimize blood pressure or optimize glycemic control to lower the risk of developing such an important complication. Thank you.
Thank you, Carmine. If there are any questions for Dr. Votta, please.
Thank you for your presentation. Very, very nice. How long is the time interval before artificial intelligence make a diagnosis of the risk of AKI regarding the occurrence of AKI? Is a fixed time interval? Is a variable? And what about the false positive? Do you have some false positive?
About the first question, thank you. Maybe I did not pay particular attention on this. There is not a fixed time before the prediction and the development. The software is trained and is validated to predict the development of AKI in the next 24 hours from the single prediction. And the prediction occurs hour by hour. I showed you that the lead time from prediction in the patient who developed in our study the AKI was about 14 hours. So 14 hours. So we made an anticipation of this time before the development. This is the time, usually this is the time in which we have to intervene for limit the problem. What about concerning these are the sensitivity and the specificity of one, about 80% like the retrospective study performed, and near all studies performed, for example, the one in the table I did not talked about, were about near the same results. Yes.
Yeah. I don't know if there are any other questions. Okay, I have one. So since basically I think this kind of solution is very new and you're one of the first to actually try it and in clinical practice, you touched briefly about what you have done after an alert or thanks to the software suggestion. So if you could like specify more about how the system changed, how you manage your patients, or which kind of clinical actions you actually did because of the software, so that also people here can better understand how this system can change daily practice.
Thank you. I think one of the most important use of the software is to works when we are working about anything else. For example, if if I work alone and I'm working outside the ICU care in that moment for example, some few hours because I have an emergency in another part of the hospital, or because I am accepting a new patient, I have an unstable patient, the software works for me and monitors the patient. So when I come to the central station, for example, to my PC, I have a visual impact that tell me pay attention to that patient. And the software may give me also some input on what to do. For example, the software may tell me pay attention to his cardiac output if I have monitored it because it changed, or the patient had a median arterial pressure lowered the limits for too many minutes or too many hours. So pay attention to this because you need to correct this. And I, for example, may choose to reevaluate the patient, to reevaluate, for example, fluid balance, volemia, inotropic or vasotonic drugs to optimize the hemodynamics of the patient. Or, for example, as I told you, it can give me the glycemia of the patient was uncontrolled for too many times. Pay attention to this and correct it, because if you leave the patient in that condition for a long, it will probably develop this kind of problem.